Hi, my name is Jody Anderson. This is NU665, presentation on endometrial hyperplasia, which is defined as a proliferation of endometrial glands and is typically categorized into two groups, EH without atypia and EH with atypia, also referred to as endometrial intraepithelial neoplasia. This picture depicts a normal endometrium and the narrowing that occurs with endometrial hyperplasia. In a study including females ages 18 to 90 from a large integrated health plan over an 18-year period, the overall incidence of EH was 133 per 100,000 women years. The incidence of EH without atypia was highest in patients ages 50 to 54 years, between 142 and 213 per 100,000 women years, whereas the rate of EH with atypia was highest in patients ages 60 to 64, 56 per 100,000 women years. The epidemiology is difficult to estimate the occurrence of EH due to many factors such as age, menopausal status of studied patients, trends in menopausal hormone treatment, assessment techniques such as endometrial sampling versus hysterectomy, and concomitant disease of endometrial carcinoma with hyperplasia. Subjective symptoms of endometrial hyperplasia: the most common symptom is abnormal uterine bleeding. Patients who should undergo evaluation for endometrial hyperplasia or endometrial cancer are those with abnormal uterine bleeding, postmenopausal patients, any uterine bleeding regardless of volume, including spotting or staining, age 45 years to menopause, and any patient bleeding that is frequent. Interval between the onset of bleeding episodes is less than 21 days, heavy or prolonged, greater than 8 days, and patients who are ovulatory. This includes intermenstrual bleeding. Younger than 45 years, any abnormal uterine bleeding in patients with BMI greater than 30, in patients with BMI less than 30, abnormal uterine bleeding that is persistent and occurs in the setting of one of the following: chronic ovulatory dysfunction, other exposure to estrogen unopposed by progesterone, failed medical management of the bleeding, or patients at high risk of endometrial cancer, e.g. Lynch syndrome, Cowden syndrome. In addition, endometrial neoplasia should be suspected in premenopausal patients who are anovulatory and have prolonged periods of amenorrhea, 6 or more months. The objective symptoms include the most common finding, which is a thickened endometrial stripe. Less common findings are abnormal cytologic findings on cervical cancer screening, a postmenopausal patient with a thickened endometrial stripe, or an incidental finding during hysterectomy for another indication. These charts here indicate the endometrial lining thickening chart during the premenopausal stage. Menstrual phase is 2 to 4 millimeters, follicular phase 5 to 7 millimeters, luteal phase 11 millimeters, and ischemic phase 7 to 16 millimeters. The differential diagnosis for endometrial hyperplasia is endometrial carcinoma. It's distinguished by invasion on histologic specimen. Difficult to make the distinction unless uterus is surgically removed and evaluated. Findings that invasion is the most definitive is an invasion pattern of glands infiltrating reactive stroma, cribiform glands, confluent growth, lack of stroma between glands, marked nuclear atypia, especially in the presence of atrophic background endometrium. The diagnostics for endometrial hyperplasia: a transvaginal ultrasound measures the endometrial thickness, an endometrial biopsy, dilatation and curettage or hysteroscopy performed to remove a small sample of tissue and determine if cancer is present. Endometrial intraepithelial neoplasia. This is an abnormal finding, also defined as endometrial hyperplasia with atypia, which has a 15 to 40% chance of developing into endometrial carcinoma. Endometrial adenocarcinoma. This is an abnormal finding defined as endometrioid type, well-differentiated cancerous cells of the uterus. In up to 40% of cases, endometrial cancer may coexist with endometrial hyperplasia with atypia, and those with risk factors such as obesity, diabetes mellitus are at increased risk, also with postmenopausal with an endometrial thickness greater than 20 millimeters. Endometrial hyperplasia treatment is shown here on this diagram. Simple hyperplasia is recommended low-dose progestin. Complex hyperplasia, premenopausal, low-dose progestin. If no response, then a high dose is given. If a positive response, regular annual biopsy examination. Or in postmenopausal women, a low dose progestin. If there's no response, a hysterectomy is done. If there's a positive response, regular annual biopsy examination. In atypical hyperplasia, premenopausal, high dose progestin, no response means they should get a hysterectomy. A positive response means hormone replacement therapy and regular annual biopsy examination. In postmenopausal women, hysterectomy is the recommendation. The preferred treatment, progesterone therapy, is recommended for premenopausal women who desire fertility, anyone who declines a hysterectomy, and women at high risk of surgical complications. Postmenopausal women who decline hysterectomy start progestin therapy. The first line recommendation is the LNG IUD, such as the Mirena, releases 20 micrograms daily initially. For pre- and postmenopausal patients with EH. If the 52 milligram LNG device is not tolerated, other options are megestrol acetate 40 to 160 milligrams PO daily, medroxyprogesterone acetate 10 to 20 milligrams PO daily, and norethindrone acetate 5 to 15 milligrams PO daily. Patient education. Teaching is done with the patient regarding untreated EH without atypia, which increases the risk of endometrial carcinoma by 10% over 20 years, but if treated with progestin therapy, the risk decreases to 2% over 20 years. Premenopausal patients start with progestin therapy or observation will have a repeat endometrial biopsy every 3 to 6 months for 1 year. If carcinoma is found, the patient will need a hysterectomy, but if biopsy shows a normal endometrium and menses has returned, the patient may try to conceive if desired. There is no more need for repeat biopsy, and if bleeding pattern is abnormal, she will need to continue progestin or combined oral contraceptives indefinitely. Postmenopausal women follow the same repeat biopsy schedule, and once biopsy shows a normal endometrium and there is no bleeding observed, it is recommended if no risk factors exist, but those with risk factors, it's recommended that patients can return to observation, but those with risk factors must continue progestin or COC therapy indefinitely. If bleeding persists, a D&C with hysteroscopy is performed to rule out focal pathology, and the patient continues progestin or COC continues with repeat schedule of 3 to 6 month biopsy performed, and follow-up is initially recommended. Health promotion and maintenance. If overweight, weight loss may help reduce or prevent EH. If the woman smokes, she should stop. If diabetic, she should make sure she's controlling her diabetes. Psychosocial needs. Reinforce the patient that EH does not mean she will get endometrial cancer. Referrals would be to a gynecologic oncologist if the patient has endometrial carcinoma. And here are the references, and thanks for watching.